Welcome to this video where we shall have a very brief discussion on anti-Parkinsonian drugs. The smooth and coordinated motor movement requires a balance between two important neurotransmitters in the brain, namely dopamine and acetylcholine. The features of Parkinson's disease may occur whenever there is a deficiency of dopamine, an excess of acetylcholine, or a combination of both. These result in the manifestations of the cardinal features of Parkinson's disease, namely bradykinesia, rigidity, resting tremor, and postural instability. Thus, the pharmacotherapeutic management of Parkinson's disease involves the use of dopaminergic drugs, anticholinergic drugs, and drugs that do a bit of both. Now, the dopaminergic drugs include the prodrug for dopamine, namely levodopa, the D2 receptor agonists, which may be classified broadly into three: those which are useful in Parkinson's disease, those which are useful only for hyperprolactinemia, and those which are useful for both. Those that are useful in Parkinson's disease include pramipexole, ropinirole, rotigotine, and apomorphine. Those which are useful for hyperprolactinemia include quinagolide and cabergoline. And those D2 receptor agonists which are useful for both Parkinson's disease and hyperprolactinemia include bromocriptine. Both bromocriptine and cabergoline are ergot derivatives. The other D2 receptor agonists are non-ergot derivatives. There are inhibitors of peripheral dopa decarboxylase enzymes, and these include carbidopa and benserazide. There are also drugs which inhibit the metabolism of dopamine by inhibiting enzymes like catechol O-methyltransferase and monoamine oxidase B. COMT inhibitors include entacapone and opicapone, and MAO-B inhibitors are classified into two: irreversible and reversible. Examples for irreversible MAO-B inhibitors include selegiline and rasagiline, while the example for a reversible MAO-B inhibitor is safenamide. Now, anticholinergic drugs used in the treatment of Parkinson's disease include benztropine and benzhexol, otherwise called trihexyphenidyl, and drugs with both dopaminergic and anticholinergic effects include amantadine. Other drugs used for the treatment of Parkinson's disease include estradiol and many others. Now, dopamine itself cannot be used as a therapeutic agent in Parkinson's disease because it cannot cross the blood-brain barrier. On the other hand, levodopa can cross the blood-brain barrier with the help of a membrane transporter on the blood-brain barrier. Once inside the brain, levodopa is converted to dopamine by central dopa decarboxylase enzyme. At the time of recording, levodopa is by far the most effective agent in the treatment of Parkinson's disease. Now, if levodopa is administered alone, hardly 1% of the administered dose will reach the brain. Now, this is because peripheral dopa decarboxylase will convert levodopa into dopamine in the periphery. And this dopamine is useless as it serves only to produce nausea and hypotension for the patient. Hence, levodopa is always combined with an inhibitor of peripheral dopa decarboxylase, for example, carbidopa or benserazide. Levodopa and carbidopa usually come as a fixed dose combination consisting of 100 milligrams of levodopa combined with 25 milligrams of carbidopa, although other fixed dose combinations are also available. This fixed dose combination is given 3 times a day. It's typically given 3 times a day. Now, we do know that effect of D2 receptor stimulation in the nigrostriatal pathway results in reduction in the extrapyramidal symptoms or reduction in the symptoms of Parkinson's disease. However, the effects of D2 stimulation in another dopaminergic pathway in the brain, namely the mesolimbic pathway, can result in aggravation of positive symptoms of psychosis, namely hallucinations and delusions. When levodopa is administered to a patient, it does bind to D2 receptors in the nigrostriatal pathway, thereby relieving the clinical features of Parkinson's disease, but unfortunately, it also binds to D2 receptors in the mesolimbic pathway, and therefore, levodopa can lead to the development of hallucinations and delusions in patients with Parkinson's disease. Now, it is true that typical antipsychotics will reverse this effect. But since typical antipsychotics will block D2 receptors in the nigrostriatal pathway as well, it will worsen the symptoms of Parkinson's disease. Therefore, atypical antipsychotics, particularly quetiapine and clozapine, are useful for levodopa-induced psychosis. However, it is worth remembering that there is only one antipsychotic that is truly approved for management of levodopa-induced psychosis. It is a selective serotonin inverse agonist, and it is called pimavanserin. Now, neuroleptic syndrome is something that we have discussed under antipsychotics. Neuroleptic syndrome occurs, it may occur shortly after the initiation of antipsychotics or after the dose of the antipsychotic has been increased, and 90% of cases occur within 10 days of onset of therapy. But we also need to understand very clearly that neuroleptic syndrome can be precipitated by the sudden withdrawal of dopaminergic drugs such as levodopa. We have discussed in previous videos that neuroleptic syndrome has many features, but the cardinal features are, of course, rigidity, severe muscular rigidity, and hypothermia. Neuroleptic syndrome can be treated with dantrolene as well as with bromocriptine. Now, levodopa itself is known to cause dyskinesias, especially when it is given at higher doses and for longer periods of time, and this is what we call levodopa induced dyskinesias. Now, there are many motor fluctuations associated with Parkinson's disease, and it is worth mentioning two. They are the wearing off phenomenon and the on-off phenomenon. Now, the wearing off phenomenon can be explained as follows. A patient is given an anti-Parkinsonian drug, like for example a levodopa-carbidopa combination, and the effect of the anti-Parkinsonian drug should persist until the next dose is due. However, if there is return of Parkinson's disease symptoms before the next dose is due, then we say that the wearing off phenomenon has set in. On the other hand, if an anti-Parkinsonian drug is given and its plasma levels are still quite adequate, and unfortunately there is an unexpected return of Parkinson's disease symptoms even while the plasma levels are adequate, then we say that the patient has gone for an on-off phenomenon. Both these phenomena are seen with long-term therapy with levodopa-carbidopa, and in fact almost any anti-Parkinsonian drug. Now let's move on to the D2 receptor agonists. We saw how D2 receptor agonists were classified. Now, among the many dopaminergic pathways that exist in the brain, there is a dopaminergic pathway called the tuberoinfundibular pathway. When this pathway is blocked, like for example when we administer the typical antipsychotics, the phenomenon of hyperprolactinemia occurs. So it's quite logical that if we block D2 receptors in the tuberoinfundibular pathway, we can treat hyperprolactinemia. And that forms the basis of the use of dopamine receptor agonists in the treatment of hyperprolactinemia. These includes drugs like quinabolide, cabergoline, and bromocriptine. Drugs such as pramipexole, rotigotine, ropinirole, and apomorphine are used in Parkinson's disease, but they are useful adjuncts. The cornerstone in the treatment of Parkinson's disease is definitely levodopa-carbidopa combination. Now let's try to understand what is the fate of orally administered levodopa. Now this is the circulation, that's the blood-brain barrier, and this would be the brain. When levodopa is administered orally, it ends up in the circulation, and with the help of a transporter, it passes through the blood-brain barrier and enters the brain. Now, while in circulation, levodopa can be acted upon by peripheral dopa decarboxylase, which converts levodopa to dopamine. Obviously, this dopamine is useless and serves only to cause nausea and hypotension to the patient, and therefore we can block this peripheral dopa decarboxylase using drugs such as carbidopa and benserazide. The levodopa in the circulation can also be converted to other metabolites with the help of an enzyme called catechol O-methyltransferase. And this enzyme can be blocked by COMT inhibitors like opicapone and entacapone. Now, the levodopa that has entered the brain is converted to dopamine with the help of central dopa decarboxylase. The dopamine that enters the brain is then broken down by two enzymes, one of which is MAO-B, that can be inhibited by selegiline, rasagiline, and safinamide, of which selegiline and rasagiline are irreversible inhibitors of MAO-B, while safinamide is an example of reversible inhibitor of MAO-B. Dopamine can also be broken down into other metabolites with the help of central catechol O-methyltransferase. There used to be a drug called tolcapone, which inhibits central catechol O-methyltransferase as well, but its use has been severely limited due to the fact that it causes quite severe and significant hepatotoxicity. The catechol O-methyltransferase inhibitors reduce the wearing off symptoms in patients treated with levodopa and carbidopa. The non-selective MAO inhibitors and the MAO-A selective inhibitors, these are all antidepressant drugs. The MAO-B selective inhibiting drugs are, on the other hand, anti-Parkinsonian drugs. The selective MAO-B inhibitors do not produce the dreaded cheese reaction shown by the other MAO inhibitors, but they can still produce serotonin syndrome. Now, regarding the anticholinergic drugs used for Parkinson's disease, the prototype anticholinergic drug is atropine. However, Atropine has too many unwanted side effects and therefore makes it useless as an anti-Parkinsonian drug. In fact, atropine is contraindicated in Parkinson's disease. There are, however, atropine substitutes which are useful for the treatment of Parkinson's disease, and they include benztropine and benzhexol, otherwise called trihexyphenidyl. Now, these drugs are useful for Parkinson's disease that has been caused by drugs, especially the typical antipsychotic drugs. We have seen and discussed in previous discussions the various extrapyramidal symptoms produced by the typical antipsychotic drugs, and we saw that acute dystonia and drug-induced Parkinson's disease can be treated with anticholinergic drugs. Now, moving on to amantadine. Amantadine is an antiviral drug. It has got useful effect against influenza virus. The influenza virus has got three important antigens, namely hemagglutinin, neuraminidase, and the M protein. Once the influenza virus enters a human cell, the M protein becomes significant because hydrogen ions, H plus ions, enter the influenza virus via the M protein, and this triggers uncoating of the virus. So these M2 proteins are absolutely essential for the life cycle of the influenza virus. Amantadine targets the M2 protein, and this forms the basis of its antiviral action. As an anti-Parkinsonian drug, amantadine appears to favorably alter dopamine release in the nigrostriatal pathway. It also has anticholinergic properties, and it also has NMDA receptor blockade. It is one of the few drugs that seems to be effective against levodopa-induced dyskinesias.